Namaste, I, JVN Dr. Juhi Singh, Assistant Professor at Jyoti Vidyapeeth Women's University, Jaipur. Today's our topic is lymphatic filariasis. In the Department of Faculty of Pharmaceutical Sciences. Let's start the topic lymphatic filariasis. Filariasis has been a major public health problem in India, next only to malaria. The disease was recorded in India as early as 6th century BC by the famous Indian physician Sushruta in his book Sushruta Samhita in 7th century AD. Madhavkara described the signs symptoms of the disease in his treatise Madhav Niradhana, which hold a good even today. In 1709, Clark called the elephantoid legs in colchins as Malabar legs. The discovery of microfilaria in the past in the peripheral blood was first by the Lewis in 1872 in Calcutta. Filariasis is caused by the several round, coiled, land thread-like parasitic worm belonging to the family Feridae. These parasites, after getting deposited on the skin permanent on their own or through the opening created by the mosquitoes, bite to reach the lymphatic system. Based on the pathogenicity and habitat, it is called into the lymphatic filariasis, subcutaneous filariasis, serous cavity filariasis, zoonotic filariasis. The lymphatic filariasis, commonly known as elephantiasis, and is a neglected tropical disease. Infection occurs when the filarial parasite is transmitted to human through the mosquito. Infection is usually acquired in the childhood, causing damage in the lymphatic system. The painful and profoundly disfiguring visible manifestation of the diseases, lymphedema, elephantiasis, and scrotal swelling occur later in the life, can lead to the permanent disability. These patients are not only physically disabled but suffer mental, social, financial losses and contributing to the stigma and poverty. The endemic in any tropical and subtropical countries like Africa, Asia, Western Pacific and part of Africa, more than 1.4 billion people are at risk. Approximate 65 residue resides in WHO Southeast Asia region. Over 120 million people are currently infected, about 40 million disfigured and incapacitated by the disease. So the Indian scenario is the overall microfilaria rate has reduced from 1.24% in 2004 to 0.29% in 2015 at the national level. Out of 255 districts, 203 has reported overall microfilaria rated less than 1%. Out of the remaining 52 districts, 31 need high priority. Also, as these districts have been persistently reporting microfilaria rate above 1%. Heavily infected areas include UP, Bihar, Jharkhand, Andhra Pradesh, Odisha, Tamil Nadu, Kerala and Gujarat. In infectious, like there are at least 8 species of the filarial parasites that are specific to the man. They Wolcheria bronchiophyti, Brugia myelia, Brugia timori, Oncochera volvulus, Loa T. persistens, T. streptococcus, Mensonella ozardi, Out of these, the three causal lymphatic filariasis. Both of the microfilaria of the W. bancrofti and B. malai occurring in India display the nocturnal periodically. The maximum density is reported between 10 pm to 12 pm. This is this is the biological adaptation to the nocturnal biting habit in the vector mosquito. The adult one differentiate the host man and intermediate host mosquito. In the adult worm, microfilaria are found in the lymphatic system of man, where they may survive for 15 years or more. During their lifespan after mating, female worm viviparous give the birth to the 50,000 immature microfilariae per day into the blood circulation via lymphatics. They may survive up to a year or more. Some of these microfilariae may be ingested by the mosquito during their blood metal. Exciating, the large come out of the sheath in which enclosed in the stomach of the fur of the mosquito. First stage larva. The larva penetrate the stomach wall of the mosquito and migrate the thoracic muscles, where it develops into the short, thin, thick form. Second stage larva. The larva more mouse and increase in the length. The third stage larva infective. The larva mouse develop into the long, thin form, which then migrates to the proboscis of the mosquito, and the mosquito is said to be infected, right? So the incubation period, intrinsic incubation period, time interval for the microfilariae to develop inside the mosquito is to third stage infective larva is 10 to 14 days. Pre-patent period, time interval between the introduction of infective larva and the first appearance of the detectable MF microfilariae in the peripheral blood is 12 to 18 months. Clinical incubation period is time of interval from the invasion of the infected larva to the development of the clinical manifestation is 8 to 16 months. The reservoir of the infection. Although the filarial infections occur in the animals, human filariasis is not usually zoonosis. In man, the source of infection is the person with the circulating microfilariae in the peripheral blood. The filarial disease, late obstructive stage, microfilariae are not found in the blood. Vector of the lymphatic filariasis, Culex, vector of Bancrofilarian filariasis, Mansonia, vectors from the Berganian filariasis. Culex breed in the polluted water. Mansonia is associated with certain aquatic plants such as Piscita, Stratoria. Host factor, man is a natural host factor. Man is a natural host. Age of all ages are susceptible to the infection. The infection rate rises up to the age of 20 to 30 years and then level off. Gender, the almost endemic area, microfilariae rate of the higher in man. Migration led to extinctions of filariae into the non-endemic area. Immunity developed only after a year of exposure. Social factor, lymphatic filariasis associated with poor sanitization, urbanization, migration of the people. Environmental factor, climate, it influences the breeding of mosquito, their longevity, and the development of parasite. Insect vector, RH is 70%. Drainage, vector breed profusely in the polluted water. Town planning, inadequate sewage disposal erosion and lack of town planning have aggravated the problem of filariasis in India. The common breeding places are open ditches, septic tanks, ill-maintained drains, ill-maintained drains, all those things. Clinical manifestation of lymphatic filariasis, stage of invasion, asymptomatic carrier stages of acute and manifestation, stages of chronic manifestation, occult filariasis. Clinical features like recurrent attack, filarial fever, lymphangitis, lymphadenitis, lymph adenomyosis in male, mastus in female, lymphedema, elephantiasis, hydrocele, and chyluria. There are some lymphangitis in the leg, acute dermatolymphadenditis in the leg, acute attack after the acute effect of elephantiasis. So chronic obstruction lessons of elephantiasis in the small children also. LF is a social evil. Lymphatic filariasis is a social evil. Disfigurement of the limb and genitalia lead to the stigma, anxiety, sexual dysfunction. The disease impediments are mobility, travel, educational opportunity, employment opportunity, marriage prospectus. Lymphatic filariasis, the drain in the economy. Global economy loss at the US $2 billion per annum. India losses 1.2 billion man days annually. Estimated economic loss in India alone and US and 850 million per year. The economic loss of equivalent to the 0.05 of GNP. Major cause of the poverty in the region. How can LF be diagnosed? Clinical examination of the filarial symptoms, detection of the microfilari in MF carry thick blood film 20 cm, microscopy at the night at 8:30 p.m. to 12 a.m. MFC method, DEC procation test, antigen detection was also there, immunochemotherapy, CT test, ICT test, fixed friendly, field friendly, sensitive and specific, easy to perform and can be done by any time during the day and night. DNA based molecular techniques also there. Filari survey, 5 to 7% of the population in the routine survey, and the 20% of evaluation studies. It consists of mass blood survey, clinical survey, serological test, zero diagnosis, and entomological survey, DEC provocation test. MF can be induced to appear in the blood in daytime by administering DEC 100 mg orally. MF begin to reach their peak within the 15 minutes and begin to decrease the 2 hours later. Clinical survey. People are examined for the clinical manifestation of filariasis, and the serological tests are also there to detect the antibodies of MF and adult using immunofluorescent and complement fixing technique, but cannot distinguish between the past and present infection and heavy and high parasite loads. Diagnosis. Mosquitoes are allowed to feed on the patient and then detected 2 weeks later. Entomological survey. It consists of the general mosquito collection from the house, dissections of the female vector species for detection and development form of the parasite, study of the extent and type of breeding places. So this is the entomological survey. Assessment of the filarial control programs, like it is assessed using clinical parameter, parasitological parameter, entomological parameters. So these are the some parameters. countermeasures can be current strategy based on the chemotherapy and vector control. So that's it. That is all about this topic. Thank you. Namaste. If you have any query, just comment below.